Oh God. Hey, you.
Hey, how you feeling?
Not great.
Great time to have a 13-hour day, huh?
No joke. Yeah, I had a meeting last night till 9,
Sorry.
and I got a meeting tomorrow night until
Oh,
9.
seriously?
Yeah.
The week from hell without being sick.
Right.
I'm so sorry.
Yeah. What can you do?
I'm going to assume we know it's not COVID.
I've been, I tested.
Not yet.
I'm negative.
Yeah, it's not yet.
It's not yet. Yeah, exactly. I just keep hearing so much about, oh, on day 1 I tested, it was negative. On day 2 I tested, it was negative. On day 5 it was positive. So
yeah, the latest is at least 5 days.
okay.
At least. I'm sorry. Do we wait for our entire quarantine to get tested? I don't know anymore. Oh,
Well, I never leave the house anyway, so it's fine. My only thing is that my husband does the grocery shopping if I'm sick, and he looks at the prices, which food.
so you might hit your budget.
Do you know how much that vegan cheese costs? Do you know how good that vegan cheese tastes? Okay.
Hi, everybody. We'll give a few more minutes for people to join. Thanks for coming.
You and I are a pair, LJ. We both got our specs on.
Oh, yeah. That's good. I'm upright. I think that's a really good thing right now.
Yep. Folks are still coming in.
Yeah, we'll give it till about 7:03 or so, and then we'll start introductions.
Okay. Per usual, gang, please put your name and practice in the chat so we have your accounted for our attendance.
Oh, we've hit 2 screens. I always figured that's a really good sign. And you move on to screen 2, though it's harder to see you all. So we thought we would start this evening while you're putting your names and your practices in the chat for attendance purposes. We actually thought it would be nice to actually just go around and actually let everyone speak for a moment and introduce themselves, because I do think that as the group has grown, especially because of the advantage of having Zoom, we are a bigger group than we used to be when we met in person. And I appreciate all of you who have taken put your screen on and are showing your face in this meeting, and encourage anyone else who's comfortable doing so. Please feel free to do that also, if you're able to. And so I'm gonna just direct, hopefully my screen won't shift too much. And so if I miss somebody, you are welcome to say, LJ, you missed me. But I'm gonna go right across the screen and just ask people to quickly introduce yourself and where you're from, and then we'll get started with our agenda. So Elizabeth Sharp, you are in the top left corner.
Oh, I would have thought it was Renee. Hi, everybody. I'm Elizabeth Sharp. I'm the Director of Performance Optimization at AHP.
And Renee is the next in line after me. Renee?
I'm Renee Sutton. I'm the Director for Provider Network Management. And if I'm showing this face, I encourage you to get on camera and show yours.
Elisa Stetzer.
Good evening, everyone. Hi, my name is Elisa Stetzer, and I serve as the Senior Director for Care Management with AHP. Nice to see you all.
Thanks, Elisa. Daryl?
Hi, everyone. Daryl Sharp. I'm a Senior Advisor with AHP.
Thanks. And Jim Wright.
Hi, I'm Jim Wright. I'm the Chief Financial Officer for AHP, and I do prefer to be the man behind the curtain, not on screen, but and taking care of the money while I'm doing that. But tonight I am here and I'm on screen per Renee's request. And just for those of you who don't know, I in my past life prior to AHP, in one of my past lives, I was the CEO and ran the Canandaigua Medical Group out in Canandaigua before we sold to Thompson. And, you know, we had 5 great pediatricians, actually 6 great pediatricians out there, one being in med peds, but you know, that's my background.
Thank you, Jim. Kathleen Wania.
Hi, Kathleen Mania, the owner of Greece Pediatric Medicine.
Thanks, Kathleen. And Robin McGillicuddy. I should qualify that. I'm sorry, Robin Shep, you're down further on my screen. I'll get you after a while.
Good evening. I'm Robin McGillicuddy. I'm the program manager for pediatric care management and social work with Accountable Health. I oversee the 9 social work care managers that cover all of our 23 community practices.
Thanks, Robin. Holly Brown, Dr. Brown.
Good evening, folks. I'm Holly Brown. I am the psychiatric nurse practitioner that consults to the pediatric care management team and a member of the BHI team. Glad to be here.
Thanks, Holly. Gail Mosher.
Hi, I'm Gail Mosher. I'm tired and rapidly aging, it appears, pediatrician from Wayland, New York. Dog years down here, dog years are happening.
Gail,
But
you are
still
awesome.
we rise, still we rise.
Thank you so much for being here, Gail. Corey.
Hey, Corey Wirt. I'm in solo practice in Brighton.
Thanks, Corey. And Pat Brophy.
Hi, Pat Brophy, Colorado Children's Hospital.
Thanks, Pat, for joining us tonight.
Of course.
Dr. Cranmer.
Hi, I'm Kurt Kramer from Kuka Family Practice in Bath, New York.
Thank you for being here.
Yeah, hey, LG, I didn't know that we had to sign in under the chat every time, so I've been at a lot of the previous.
Don't worry, we've been catching you, Dr. Kramer. Don't worry. It's just, it helps us a little bit, but Renee's all over it every time.
Right.
No one needs to worry. We got you accounted for. Thank you.
Thank you.
Sue Miller.
Hi, Sue Miller, Goodman, pediatrician at Goodman Pediatrics in Arundecoit.
George.
Good evening, everybody. George Nasra, psychiatrist. I'm the associate medical director for behavioral health at AHP. Happy to be here.
Thanks, George. And Carolyn Cleary.
I'm a pediatrician at Elmwood Pediatrics in Rochester.
Carol Gagnon.
Hi, Carol Gagnon from Westside Pediatric Group.
Doug Bennett.
I'm Doug Bennett, pediatrician and Arundecoit Pediatrics. And Arundecoit, obviously.
And just so people know, I don't know if people are aware of this, that Dr. Bennett is now on the AHP board also this year. So, and for those who don't know, Carolyn Cleary is the chair of that board. So pediatrics is well represented in that space. Just wanted you to know.
Take over soon.
Excellent. It's all part of the master plan. Just don't tell anybody, Doug. You got to keep it under under the radar. Katie Edwards.
Hi guys, Katie Edwards, pediatric nurse practitioner from Stony Brook Peds down here in Dansville and Geneseo, New York.
And Lynn Efron.
Hello, I'm Lynn Heffron. I'm a social work care manager at AHP, and I support patients at Elmwood, Arundecoit, Dr. Lewis, and Patchwork down in Perry. Good evening.
Good evening, Lynn. Thank you. Christy Howd.
Hi, I'm Christy Howd. I'm the Director of Information Management at AHP.
Thank you. Sarah DeVicki.
Hi, Sarah Dovicki, Fairport Pediatrics.
Thanks, Sarah. And Robin Shep, now it's your turn.
Hi, guys. I'm pediatric social worker from AHP, working with Eastside in Stony Brook.
Thank you. Lisa Smith.
Lisa Smith, pediatrician at North Greece Med Peds.
And I see I have a plant strategically placed in my head.
Lisa, I'll tell you, I saw the funniest thing ever. Somebody actually took a picture of themselves on a Zoom screen where they just had happened to sit in front of like some sort of a raised sculpture on the wall, but the raised sculpture looked like it made it look like their hair was literally standing up, and it was honestly the funniest thing I have ever seen.
You'd think after 2 years of Zoom meetings, I could come up with something better, but sorry about that.
I think it's pretty good. All right, Jen Lessick.
Hi, Jen Lessick from Mendon Pediatrics in Mendon.
Nikki.
Hi, I'm Nikki Spring. I'm a social work care manager with Brighton Pediatrics, Henrietta Pediatrics, Westside Pediatrics, and Genesis Pediatrics.
Thank you, Nikki. And Laura Markwick.
Hi, I'm Laura Markwick. I'm a family nurse practitioner at NP Family Care Rochester here in Rochester, Brighton.
Thank you for joining us. Willie.
So Willie Newdegate, Information Systems Project Director here at AHP.
Excellent. Mary Beth.
Mary Beth Robinson, 12 Corners Pediatric.
Thanks, Mary Beth. All right, and now my screen just did a funny move. So give me 1 second. Emily, I think is next.
Hi, I'm Emily Ellicott at Henrietta Pediatrics.
Thanks, Emily. And then I think we have like 2 phone numbers. If I missed another person whose face and name are on the screen, forgive me, but everything just did one of those flips. So now I've lost my orientation. Actually, Elizabeth has now gone to the bottom of my screen of all things. So I'm very disoriented. We have 2 phone numbers on a 943-9828. I'm not sure who that might be if they want to introduce themselves. There's also a 245-1760. Well, I'm just going to say we're not saying anything too exciting tonight, so any Zoom bomber would be very disappointed. But whoever it is, if you're able to unmute at some point and want to share who you are, please feel free. I want to apologize for my voice and sort of the speed of my ability to assimilate things. I will share with you all, like I now am a COVID casualty. I am just getting released from my 5-day isolation. And so I just do want to say it is still out there. I think we may be underreporting a bit of what's happening. And I'm seeing head nods. It's unbelievable. So we weren't planning to talk a lot about COVID tonight, but we've got some time at the end. It's just be open discussion if there are things y'all would like to talk about. But I've specifically reordered the agenda so you're along for the ride now. So don't be paying too close attention to your agenda. Part of it is so I'm not talking a whole lot actually, but also to feature some of the good people around the table. I just wanted to say I love coming to this meeting. Actually, I miss when it was in person. You really are a remarkable group of people to work with and to partner with. And so I hope we cover some good ground tonight. So we're actually going to start tonight with something that's not on the agenda, but was brought to our attention by Doug Bennett. I'm going to turn it to Renee to talk about a contract being offered by Fidelis. And Jim is going to speak to this too. Renee?
Thanks, LJ. And thanks, Doug, for bringing this to our attention. And many of you who are currently contracted with Fidelis may already be aware of this, but for those who are and haven't noticed this pop in the mail, we wanted to make sure that you knew this was on its way. Fidelis is sending out an amendment to your existing fee-for-service contract, or not sending it out. They're informing you that they have amended your fee-for-service contract by making you participate in their incentive program, which has no downside. It's all upside. Not a great program. And the notification though is for you to opt out if you so choose. And I asked Jim Wright to attend with his background, both from the practice management side and as our finance guy and a member of our contract negotiating team, just to briefly give his take on what this may mean for your office. So Jim?
Yeah, I gave it a quick look today, read it all over. And I think, kind of in the email exchange between Dr. Bennett and Renee, it is highlighted. It definitely is a program that's more adult centric. there's a couple of very, standard HEDIS pediatric measures. You have the childhood and the adolescent vaccine combo measures, and you also have the well child measures. So, you have all three of those on there, but the only other ones that really involve pediatrics, there's a couple of ED visit, ED with mental health, ED with substance abuse. And I was a little underwhelmed by those measures and how they were set up. Bottom line, though, is I believe all the measures are HEDIS measures. All the measures, I believe, are status quo. I believe they're work you're already doing. I don't think they're added work to what you're doing. If they are added work, then I think you just have to evaluate, is it worth the additional work? Because I can tell you there is no downside. It's an upside only thing. So if it's part of your status quo, if it isn't going to cause you extra work and your systems are capturing this, it's just what you do. I see no harm in it because it's upside only. I mean, it doesn't appear there's any negative, like I don't think they're going to rate you negatively or anything like that. One of the challenges, if it does create extra work, is it isn't just based on how you perform, it's how the region performs. And because it is adult centric, and there is no separation, like where AHP says, these are the pediatric measures, and we're just going to rank the pediatricians in the pediatric measures. This is just combining everything together. So you are going to be held to how the adult measures perform in your region, and it is some comparison to other regions is how I'm interpreting it. And I think Renee, based on your email, you interpret it the same way. So once again, if it's something that's going to cause you extra work, I might be hesitant. I'd have to evaluate what you think that's going to be. But if it's something that's part of your status quo, I don't think there's any harm. I don't think there's any guarantees that you're going to get more money, but you could.
I have a question, Jim. I mean, I know that it shouldn't affect our fee for service. This is Doug Bennett.
Yep.
It shouldn't affect our fee for service that we're currently getting, but I know Buffalo region and Syracuse region that they're over time that they get paid, their reimbursement's less now, and they get more value-based. So it could be something that's coming our way, and this is just the first step going in that direction. And so I don't know what we can do to prevent that or to be prepared for that.
I mean, I have to tell you, everybody should be getting Fidelis should be paying the Medicaid rate, and they shouldn't, I always said when I was in Canandaigua, we should never accept a lower rate. And in fact, I always used, MVP was paying us, the Medicaid rate. And in my opinion, Fidelis should pay the same thing that MVP and Excelis are paying. So yeah, I think, people just have to hold the line and not accept less than those rates on Medicaid. But yeah, I do understand your concern. I mean, it's obviously it's something you got to stay on top of. I'm not going to pull any punches. I'm not a big fan of Fidelis. We've not been able to negotiate a contract with Fidelis because they don't want to meet our terms. And in fact, we have solid contracts with Excelis and MVP, and we're sure not going to sign something with Fidelis that's lesser than what we get with the other two.
Jim, I thought HP had some sort of thing with Fidelis, not a formal contract.
It's just fee for service.
Yes.
So.
Yeah, and I know HP does not have any United Healthcare contracts, but I did let Bob and know that, and Doug probably can comment to this. I think the United Healthcare Community Plan was cutting their rates by 40%.
Okay.
Doug and Carolyn, I appreciate
that I hadn't noticed. I mean, I didn't get any rate changes, but
there was some sort of notification that went out to the office manager, and our office manager mentioned it. And I know Monroe County Medical Society has been notified and is supposedly going to work on it, but I doubt they make a lot of traction because it's a national healthcare plan. They don't listen. They listen less than Fidelis possibly.
And I have to say, in our area, I'm only aware of United having a Medicare plan. I don't think they have a commercial plan.
Well, they have Medicaid for sure, and they do have a commercial
Oh,
plan.
okay.
It's not large, but they have it.
Yeah, they've only ever spoken to us about Medicare, so.
Yeah.
So I'm curious if there are any other questions for Jim on this. We just felt it was timely and wanted to bring it to the group's attention. And Jim, I appreciate you being here and also appreciate the fact that you brought up why we don't have a value-based contract with Fidelis, because I think that's confusing.
Yeah.
For
No,
our
we
team.
tried and they didn't want to work with us. And we've revisited it numerous times. So, and you know, if you have questions after the fact, you can always go through Renee. We're happy to look into anything for you. So.
Excellent. Okay. Just making sure there's no other questions. Looks like no one else is unmuting. Okay.
And
Thanks, Jim.
I apologize. I do have to sign off. I've got another meeting at 7:30. So.
No problem. Thank you very much for joining us. Okay.
Yep. Have a good night, everyone.
Okay. So we're completely flipping the agenda around a little bit more, and we're going to move to talking about the quality measures, and Elizabeth Sharp is going to go through the quality grid for 2022.
I am. I'm just going to share my screen very briefly. I have a couple slides, not too many. Oh, I got to click into the presentation in order to advance it. So wanted to show folks what we're talking about for the 2022 Pediatric Quality Program. Can you guys see my screen okay? Okay, good. I was getting some weird looks, but I guess it's just the faces of my lovely colleagues. We are taking a look this year at childhood immunization combo 3, adolescent immunization combo 2. Those are the same combinations that we looked at last year. Well care visits in the first 30 months of life. So I call out on the next slide the changes. I'm actually going to pop there for a second and pop back over to the grid. We have removed lead screening from our quality grid. And the reason for that, we've spoken with a number of you about the recall that happened with the LeadCare2 analyzers. We're happy to report, for those of you that haven't heard, that we are back in the business, not AHP in particular, but up and running with the test kits for the LeadCare2 analyzer. So the manufacturing should be up and running, good to go by June, but we didn't feel that it was fair with the large gap based on the point of care testing recall to hold people accountable to that. We will still be talking to your practices to make sure everyone's still comfortable with their workflows and everything. We're still very much in favor of point of care lead screening and lead screening in general, but didn't want that to be held against anyone. And then I have here, we added in the well child 15 to 30 months as a report only measure. So popping back to this grid, you'll notice that the well care visits are now, it's well care visits in the first 30 months of life. The 0 to 15 we've had on our grid for a long time. That's a pretty normal measure. You should be used to seeing that one. The well care 15 to 30 months is the new measure. And what we're looking to do here is include it on the grid because we have to take it if we want to take the 15 months, but include it as a report only measure for our physicians in the same way that it's being included for AHP. And what that means is that for 2022, everybody's going to get full points for it. So we're going to be taking a look at the data, making sure we're pulling things through, identifying any issues we have, with the understanding that we'll be taking that as a pay for performance in 2023. I'm just going to pause here for a moment and see if anybody has any questions about that new measure. Okay. I also have depression screen and follow-up on here. This is not going to be included on the quality grid, but it is a part of our incentive program. It's going to be on the provider engagement report. And what we're looking to do there is increase screening by 15% from the previous year up to a threshold of 75% of patients. I don't have that part noted here, but we'll build that in. If your practice is already screening more than 75% of your patients, that's fantastic. We don't want you to stop, but we didn't want to kind of set that threshold too high since we're not working with the strict HEDIS quality measure definition there. I'm going to pop over this screen because, again, removing the lead screening, adding in the well child 15 to 30 months. Some resources at your disposal on our website. Under partner resources, if you look at the top here, you click into partner resources, you can click quality measures, and we have essentially a one-page definition for each of our quality measures. So if you're ever wondering what counts, what satisfies the quality measure, this is a great place to go. We can thank Willie Nudigat for creating these beautiful one-pagers, and I just pulled up the adolescent immunizations. So it's got a brief overall description, the qualification, so what pops the patient is the denominator. satisfying the measure. So what makes them numerator compliant? A couple other things to call out. You'll notice the targets up here. You can see what the thresholds are for the 90th, 75th, 50th, and 25th quartiles. And interestingly, I won't say more importantly, but interestingly, you can also see the changes from previous years. So if the thresholds went up or down, that's important to note. And so we wanted you to have some insight there. Additionally, if there's any clinical resources, any initiative work, anything that AHP has worked on or that's currently being done, we have a link. There are other ways to get to that clinical information, but this is a nice clean route. And so, for example, for adolescent immunizations, we have some information from the clinical grand rounds we did and the vaccine same way, same day. So you can click on that link and it will take you directly to the clinical resources. So tried to bundle that for you. If you or your practices have any questions, you can always reach out to myself, to LJ, to Willie as well. That's what I have for you all today. I believe that Willie had a brief update to jump in with.
Yes, I do. So I wanted to provide a quick update on the Arcadia upgrade that was originally scheduled for the end of March. Obviously, that didn't happen. During our testing, we found a number of issues with the measures and with the back-end database that would have had a negative effect on what you saw on the front end. So with these upgrades, we want to take a step forward and not a step back. So with the severity of those issues, we didn't have Arcadia move forward with the upgrade, but we continue to work with them on the issues with hope that we can transition to version 6, hoping by the first week of May at the earliest. So fingers crossed.
Thanks, Willie. So we'll be sending out updates, you know, if it looks like that's when that's going to happen.
Absolutely.
Excellent. I just wanted to circle back with 2 questions around the information that Elizabeth presented. The first is, you can unmute or show of hands, how many people who already have who have the point of care led Care 2 machines are already receiving their test kits? And how many are still on back order? I could say they're almost like half and half. Okay. All right. So it was our understanding, as Elizabeth said, that they were able to start redistributing to some vendors, practices, whatever, but that they didn't expect to be fully back in distribution mode until June. So we are planning to just circle back around with everybody right at the beginning of June and make sure that everyone is receiving. We don't receive the kits from them. We don't have influence there, but we do want to make sure that everyone's getting back up and running with their test kits appropriately. And I wouldn't hesitate to reach out to the company directly if you haven't had any contact from them whatsoever and see where you are on that wait list. I think would be very reasonable to do. The other thing I just wanted to highlight one more time about the well care visits, the 0 to 15 month and 15 to 30 month. When this was first presented to us as part of the quality grid from Excel, there was an assumption we would just sort of take the whole thing. And we really did ask to break it out, because I do have this worry, this little worry in the back of my mind, that the way the definition is written for 15 to 30 months, that it might actually be a little tricky to get to those 2+ visits if for some reason the timing of a child's visits were just off a little bit. And we should be able to achieve 2 visits, the 18-month and the 24. But the goal of this is to emphasize the importance of the 30-month visit. So I would just encourage for any of you who have the ability within Meta, and obviously we can't do this within Arcadia because we don't have that build to do it, but within Meta, to just take a look and see how your practice in general, if you were to break out that definition and look at a subset of your patients or a broader set of your patients, how you're doing in that space. And if you're willing to share that with us. We just wanted to be very cautious about agreeing to anything before we had a good baseline and before we were sure the data would pull through appropriately. I know it's bread and butter of what we do, but sometimes the definitions of these, that's where the devil is in those details, I think, for us to be able to meet the HEDIS metrics at times. Doug, yeah.
I'm a little concerned about the leeway. I mean, the cutoff at 15 months and 30 months, because many times we might be 3 weeks late with that, and we still call it our 18-month visit and our
exactly
2.5-year visit. And I think there's going to be problems
that's why we sort of put up our hands and said, like, I mean, we had to have some pediatric measures, but to say like, we're not sure this is really gonna work. And there was no way to set any thresholds because we didn't have any baseline either with that. So anything that real examples, what your experience is, what this looks like in your practice, we would love to hear that. Thank you.
LJ, can I ask a question while you cough there?
Please do, because I got to cough more. Go ahead.
Okay, it's Mary Beth Robinson from 12 Corners Pediatrics. This is a little off the topic, but the HPV, our office, I think, has an exceptional uptake for HPV, but for as long as that vaccine's been available, we've given it, we discuss it at the 11-year-old visit, at which time we give Adacel and Menactra, and we give it at 12 and 13, which means we never make the measure because it's got to be by their 13th birthday. So we changed a couple years ago to try to give it at 11 and 12. And our uptake went way down, way down. People refused it because they didn't want 3 vaccines at age 11. Then they got weird about it, and then they didn't want it at 12. And we went from, you know, internal review of something like 97% uptake down into the 70s. So we stopped and went back to 12 and 13, and the numbers went back up. But, you know, we just said, all right, we're just not going to meet that metric because it's bad for our patients. I don't know if other people are having that. I don't know what you can do about that, but it is a concern of ours.
I'm curious if anyone else. Go ahead, Carolyn.
No, I was gonna say, I know Dr. Rand is on and she may want to comment. We switched to giving HPV and Tdap at 10 and you know, at 11 do the second HPV and Menveo, and we have not had a problem at all.
Yeah, I was going to say something to that effect. We do Tdap at 10 in part to catch those late bloom, you know, the late kids going into 6th grade who are still 10. And so it seems like just doing 2 at a time is good because then you can always get that second dose of HPV in. So it maybe just means shifting everything down by 1 year would work.
We did do that, but we found that parents were more resistant at the younger age. That you know, we presented it the same way. Okay, today we get HPV and Menactra, and people refused.
Even when you only had 2 at 11?
Yeah, just because I think of the earlier age. You know, we explain it's often, you know, it's approved for 9 years old, and something about suburban 11-year-olds, their mothers are not ready.
10 might be
One
even
thing I would-
easier. I don't know. For some, 10 is easier because then you're not even thinking about like what it's for.
I just want to remind the group, as it relates to adolescent immunization for 2022 for combo 2, the 90th percentile is 41.52%. So the bar's kind of low.
Hello. We're way above that.
So,
but still, I wonder if the metric is misplaced.
I think this has been debated from the very beginning, and there has not been, despite, you know, multiple years of comment on the HEDIS metrics, because these aren't metrics that obviously this group sets or even our local insurers set. You know, this really is the national HEDIS metrics. There does not appear to be any anticipated movement or change in that. And Cindy Rand, you probably know this best, but to the best of my knowledge, that is unlikely to change in any way.
I don't think it'll change.
Right. Yeah. I don't
Can I speak
know.
to?
Yes, go ahead, Carol, please.
We have had very good luck, just like Carolyn Cleary, and we've been doing this for a while. I started doing it when Pete Szilagyi sort of recruited me to do some help with him through a study he was doing out of California to look to see if we could get kids vaccinated earlier, 9 or 10 years old. I think our GH's clinic is doing 9 years old actually, but we do 10-year HPV Tdap just as a given. And I would tell you that the vast majority of the families are accepting of it. And if they aren't, most of them, if they never do it, they never do it. But at most, they might say, can we just wait and do that at the 11-year visit? And then I remind them, well, at the 11-year visit, there will be a meningitis vaccine there too. So, you can make your decision. And I personally have the patients come back in 6 months to finish it because I don't want them then to not get the second one at the 11-year visit when they know for sure they have to get the meningitis vaccine. And we've had no pushback, not a lot. I mean, and we have, kind of a mix of suburban patients, maybe not so much the Brighton or Pittsford, but I certainly think we have quite a, we have a lot of the West Side families. So that's really been a plus. And I was doing that as the only physician in the practice. And then when my partners kind of came on board, that were waiting at least until 11 or 12, their rates really, really, really went up. So, and as Renee pointed out, the quality measure, I mean, I certainly think it should be higher than 40%. It would be nice to be closer, maybe to 60 even. I think that would be more realistic, looking across the board. So Mary Beth, my sense is just, keep working, just keep trying. And if it becomes standard of care at the practice and all of the partners are doing the same thing, you might have better luck.
What we went from was like 97% down to like 84%. So we were still way above, but to us, that seems significant. It was just, wasn't us presenting it differently. I mean, the numbers were still high, but it was a drop, and that seemed like going in the wrong direction.
I appreciate you sharing your story, Mary Beth. And I remember the conversation where you back before you made that change, within your practice and hearing what happened. And I also appreciate everyone else sharing their experience in this. I think the best that we can do in these spaces is being able to give families the information to make a good decision and the space in which to do it, the multiple spaces, I guess, in which to do it. So we'll continue this conversation more, and I appreciate all of you sharing. I'm going to turn it over now. I'm going to ask Holly to talk a little bit, in introducing this before I start to cough again, because it's coming. We have spent a lot of time, I think, individually talking, many of you as practice teams talking with your care managers or with the BHI team, and just all of us sort of coping with a very reactive world around us. And I think your staff, you as individuals, have taken a lot of very negative heat and, again, reactivity from patients, from families. And so coming from a lot of requests around how can you manage that, Holly's going to talk a little bit about sort of both effective boundary settings and then strategies for managing stressful situations or challenging situations.
Yeah, thank you so much, LJ. And I think the conversation really started last summer around incivility and patients giving folks at the office a pretty tough time, particularly around vaccines. That was an area that was pretty stressful when I talked with providers last year, and LJ and Daryl and I kind of got our heads together and said, we got to be thinking about this. And it dovetails nicely into the trauma-informed care work that folks have been engaged in related to the grant project that Dr. Sharp, if you want to say a few words about it afterwards, I certainly invite you to do that. But we had a request, a specific request around developing some content around strategies for de-escalation and thinking about partnership with patients and families who may have some present as escalated. And my colleague, Sephora Rosenberg, which some of you know, had started this on the adult side. And when the ask came through with one of the trauma-informed groups about pediatrics, we said, yes, let's do that and adapt that presentation for a PEDS community setting. So we were able to do that. It feels like a long time ago, but I think it was 2 weeks ago now over at Long Pond Pediatrics. We were able to do it in person, which was absolutely fantastic, and enabled Sephora and I to live into the interactive way that we wanted to deliver the talk. And really the conversation is around defining de-escalation for the teams, to engage the teams in a discussion about sort of what have they experienced around escalated patients, what did they notice about themselves in response to that. So there's some components on self-awareness, noticing the environment. What are you noticing about the person who was showing up in that escalated state? We talked a bit about why people might show up escalated to a pediatric office. And many of you will identify those things real quickly: fear, uncertainty, unmet needs, frustration in general, certainly are factors that contribute to parents and kids showing up escalated. Anger, another one of those things. So we spent some time going through the signs of escalation. What do you notice in the other person that would prompt you to wonder about a person being escalated? And then really, what is the goal? When you're with a patient who is frustrated, presents in a hostile way, our goal around de-escalation is really around building rapport, connecting with folks, reducing that, working to reduce that escalation overall. And of course, controlling our own responses to that, right? Because folks can say some pretty troubling things to us. And so we want to recognize that we're all human and we're going to have a response. But really what's key to managing that situation is managing ourselves. And then we went through a series of 10 tips that could be utilized and practiced a little bit with the team at Long Pond to give examples really, and talked about particular situations that they offered. But some examples of some of the things we discussed were maintaining a posture of empathy, calm and non-judgmental perspective, really focusing on the feelings that are behind the person's behavior. Declining the dance, right? Because folks, when they're escalated, can invite us to a power struggle, and that's only going to make things a bunch worse. So really working to avoid that power struggle. And then, of course, being clear about limits. I think we spent a fair bit of time on limit setting with patients, how to do that effectively, and managing that situation. So at the end of it, we talked about leveraging the team and really inviting people to a conversation to talk about how do the teams, the nurses and the front end staff and the physicians and nurse practitioners, how do y'all work together when you're faced with a situation that folks present in an escalated manner. We also talked about the importance of debriefing, because many times you get into a situation and you're off and running to the next patient and there's no real time to breathe and process what just happened. And that adds to the trauma experience, the distress that you all experience in those encounters. So talked a bit about that, and then just helped the staff to identify some concrete strategies for partnering with one another as well as patients related to de-escalation. So it was a fun time. It was great to be in conversation and in person. Again, that interactive piece was huge. And we are happy to offer that up. If folks have interest in working with your staff, we'd be happy to do that. So Daryl, any words you want to add related to the trauma grant or any? You're muted.
Thank you. Thanks, Holly. Not a whole lot for me to add, just that just a reminder that grant involves five AHP practices. 2 of the practices are Pediatric, Long Pond, and Stony Brook. And one of the great things about the grant is our purpose really is to disseminate trauma-informed approaches throughout those 5 practices and ultimately across the whole network. And so we're working with CCSI, which is a consulting group in town. And they've done a really fabulous job working with us, a lot of good content. There is going to be a series of videos that are going to be available to practices by the end of June. And those small videos, they're short videos. They will have facilitation guides with them, and our 5 pilot practices will be learning how to work with those. So our idea is to build resources, a resource toolkit for all of you. And then with our team, our care management team, BHI team, equity council team, to support you in this work. And so this is an example of the kind of thing that we will be offering up. And it was really great because the presentation was done initially at Strong Internal Medicine, and through the grant discussions, we began to share and cross-fertilize, and that's how we landed here. So that's the grant in a nutshell. I don't know, LJ, if you have anything more to say about that. LJ's not speaking right now.
Oh, I have a cough drop now.
Oh.
I got some water, but no, I think you covered that very nicely. I just wanted to highlight again, what Holly said. I think that, some of the work we end up doing together is the collective work around quality measures or various types of clinical improvement projects. But nurturing your practices and supporting your practices, the work of our care management, our care managers, and the BHI team, that this kind of thing is so important and has become, I think, just so much more significant. So please don't hesitate to reach out to our team if you're interested in that de-escalation training for your practice.
There is a question in the chat. Is there any reflective supervision or nonviolent communication in this model?
Dr. Wania, which model, in the de-escalation talk or in the trauma-informed care grant as a practice?
Trauma-informed care grant.
There's lots of reflective supervision. Lots. I mean, I would say that is at the heart of a lot of the work that we're doing. And certainly nonviolent communication, that absolutely is an essential component. So I would say yes.
Okay.
In a big way.
I think the nonviolent communication strategies are really concise and can be very helpful. So maybe that even could get in that de-escalation if people aren't interested in the full trauma-informed care model.
Yeah, that Dr. Wania, that is in the, we do talk about that in the de-escalation talk. Yep. The communication piece. And really, I think the debriefing sort of touches on that reflective supervision. So there's lots of ways that gets touched on for certain. And I think we're modeling that in the grant itself too.
Great. Thank you.
Any other questions or comments for Daryl or Holly? Okay. So now we come to the roundtable discussion. So this is, we are not going to talk about LARC tonight. I just know I cannot present for any length of time. It's going to be awful for you all. It's going to be worse for me. So we're just not going to do that. So we will end up giving you a little bit of your time back. And we will have a more rounded out presentation about LARC at our next PCP advisory group meeting, which is June 1st. We're going to invite the Hockelman Center team to join us, Andy Aline, possibly Rachel Phelps, if she's available, to come and chat with you, kind of update you on what's happening in that space. But in just kicking off, the roundtable is really anything else that you all would like to bring to the table or would like to talk about, things you'd like for us to be thinking about that are important to you for your patients or for your practice teams. And I'm going to start it off with a question for you all first, which is, I think you saw the first item in the agenda was to talk about an in-person gathering. And as I sit here recovering from COVID right now, I think, what in God's name were we thinking to even put that on an agenda a couple of weeks ago or a week ago when we put that out? But I think what we're really talking about is, looking towards the fall, when we'd like to do some kind of a larger group meeting, Zoom or otherwise, for our pediatricians and family physicians, what might you like to have featured in that? I think we're tabling the idea of how it happens. Just knowing what the fall tends to be, it may well end up being a Zoom meeting, but we were thinking, broadly speaking, about a maternal child health grand round, something that's really, we could bring in our colleagues in OB and maternity care, as well as our pediatricians, med peds, and family physicians. And just curious if you have any thoughts about that, any topics you'd really like to hear about, things that might be important to you, and if that feels like a good idea to make it a little more broad, to make it maternal child health rather than just pediatric or adolescent. So you can throw things in the chat, you can unmute. I am muting because I can't talk more, but please feel free to speak on that and then take the topic somewhere else if you want to. I saw Corey, I'm talking still, the rising home births. It's a great question, Corey. I don't even know the data around that. Do you want to comment?
Yeah, it seems, well, it's just like I've had now 3 families who have done, 2 of them I've done through like a nurse practitioner or some kind of midwife or something that they're doing home births. And it's a little unclear when my role, like they've had other children in my practice and now all of a sudden are choosing a home birth, and how that incorporates. Like some of these kids I've never laid eyes on, they're almost 6 weeks old. And you know, how we handle that. And I have another family that I know is planning to, they're supposed to deliver at Strong and they are fully not planning to go in, and that's not going to be a supervised birth. And but it just seems like it is a trend now, and I don't know whether COVID, because people couldn't be together as families or whatever, and you know, I don't know, or people's reluctance to be in the hospital, but it seems to be a more common thing happening in our area. I don't know if other people are having this issue and how that's going to impact us, because we're kind of straddling roles, you know.
Thanks for bringing that forward, Corey. We will definitely put it down and do a little more exploration and bring it back to the group. I don't know if anyone else has any other comments about that. Do I like the idea of having a more of a pediatric focused grand rounds? There was an adult grand rounds that AHP did this year. We had intended to do a pediatric one in the spring, but we're thinking at this point that it might be better suited for it happening in the fall, just for planning purposes.
LJ, it's Mary Beth again. One thing that I think might be interesting, you know, it's been years now since many of us have been in the hospital, the NICU in particular, and things seem to have changed with feeding protocols and preemies and follow up on, you know, hip dysplasia and et cetera, et cetera. It might be nice to have a little summary of kind of what's new in neonatal medicine, because the handoff is, you know, sometimes the only time we hear is in that discharge summary, and it might be nice to hear some of the reasoning and the longer term plans. How long do we use these special formulas, things like that.
That's great, Mary Beth. Thank you. I wrote that down.
Yeah, I completely agree with that. And I don't know, the pandemic trend was to dump mothers and babies out very quickly because they didn't want them in the hospital. I do worry that the OBs as well as the hospital and the insurers and everybody will attach onto this, and everybody gets discharged at 24 hours. So, you know, if there's a comment about if that's going to continue the trend, and also slightly better sign outs, if you think the baby is being discharged Friday and they have to be seen Saturday or Sunday, it's fine if you send us a fax and we do manage to catch them, but it's not great sign out. So things like that.
Great points. Thank you. Other thoughts?
I guess I can comment on that too, LJ. I can think probably in the last few months on my Saturdays, I've had to readmit newborns that were discharged just so quickly. And it says right on there, you know, you need a Billy and you need to be seen tomorrow. And it's clear, like, and the families are frustrated because I have to put them, luckily I'm able to put them right there at UR Noise, you know, New York Med Noise, but it's just really quick the way they seem to be discharging them. And I just had a kid today that was discharged from Jones, that they were concerned about NAS protocol stuff, that they didn't keep them the full 5 days. And now I'm worried the kid's having some withdrawal stuff. I just didn't know if everybody was kind of following the same rules or, you know, but it sort of seems a little fragmented and screws up the readmission stuff, you know?
Yeah, it's not great for the babies and the families either.
No.
Okay, those are great suggestions, all of you. I mean, I'm hearing sort of what's new, protocols, appropriateness of early discharge, what the handoffs are and signouts are, and trying to prevent readmissions. Great.
Since we're on a roll, LJ, I'll just
Keep going. I love it.
one more thing. I don't know how appropriate this is for an AHP forum, but we have had a tremendous amount of trouble getting communication from CPS. We have a number of families, some newborns who are being discharged with CPS follow-up, some, you know, school phobia kids who haven't been to school in 2 years who are trying to involve CPS to get these kids back in school. The list goes on, but we aren't getting calls back. We're not able to figure out who's assigned to the case. No one seems to be following up. I don't know if getting somebody from CPS to talk with us about what's the best way to access their services, what's the best way to implement preventive care, those kinds of things.
Those are such important topics, Mary Beth, and I'm going to actually turn to, I don't mean to put Robin on the spot, but when I think about somebody who knows a lot about CPS, I'm looking at all of the care managers on the screen. Actually, all of you have just had my eye on you. Robin or Nikki, anybody like to comment on that? And maybe that could be something we could bring in as a topic next month, or not next month, sorry, June, with our next PCP advisory meeting.
Sure, I think it's always a hot topic because we have, you know, even county dependent, different thresholds in terms of what is, you know, what their policies are in terms of, you know, just safety and when they're determining, you know, children need more, and there's always the voluntary status around receiving services. And then of course it's a long process to have services court mandated. So it's very complicated in a system that is overrun and, you know, underfinanced. But I think there's also a lot of changes going on. And I think, you know, being able to identify somebody to come would be, I think it would be beneficial for us all. But there is a large amount of variation across counties and sometimes among different workers. So, you know, we certainly would want to work together with them and get a sense of at least the majority of our practices. The majority of them are here in Monroe County, so we certainly could find someone that could give us some information. But I think there's a considerable amount of variability.
Thanks, Robin. And I noticed Nikki just put in the chat that the hospital has a CPS consultant connection with Monroe County. That may be a resource for us that we could explore as well. So we'll take this back with the care management team for peds and kind of explore a little further and then sort of think about what we could put together that would be both informational and sort of relationship building too, right? I mean, that's what some of this is. You know, the people keep changing and the workload keeps increasing, and so the more that we can be relational with these partners and then figure out best workflows, it works better. Good. All right, you're on a roll. I'm waiting for another one. Anybody else have any other topics that they'd like to think about for the grand rounds, or just doesn't have to be that? It can be, is there something you would like for AHP to be focusing on for you and for your patients? I was told recently that you're supposed to count to like at least 10 or 15 to let the silence go, but I'm really bad at it. It makes me very anxious. So you can see I jumped in sooner than 15 seconds. I'm just looking at screen 2 to make sure that I didn't miss anybody who was muting themselves. I see another chat message. Well, thanks, Cindy. That's a good point. Scott Hartman over at Highland Family Medicine leads the implicit group that focuses on intrapartum care. That's another great resource. Thank you. Good idea.
Hey, LJ, for whatever it's worth, I don't know. I want to bring up lately we've been getting a lot of requests to provide support to parents in the NICU. So this is an area that really falls through the cracks because these parents are not patients. Our consult service cannot provide consultation to them. They're really going through a difficult time. They really don't understand a lot of what's happening. The nurses are get frustrated and really overwhelmed because they are trying to do their best. So we're trying to find ways to provide more support with the NICU babies, of course, but to the parents as well. So that's one thing I wanted to put out there.
And George, isn't Projects Teach, that may be a consultation to their adult providers, but they're doing some sort of, even though Project Teach is usually pediatric, psychiatric, they're doing something for maternal, peripartum issues. I don't know.
Yes, that's a great, to be honest with you, I didn't think of that as a resource because I'm thinking of Project Teach as a consultation, but they need hands-on.
Right. And it's not clear to, I know that this is a new thing they're doing. It's not clear to me. And I think they're probably still less hands-on, but if a primary care doctor of these parents contacted them, they theoretically could do something. I don't know.
I'm going to look into that. That's a great thought.
Thanks, George.
LJ, I didn't know if, huge shout outs to the care management folks and Dr. Brown, they're meeting with us weekly, but I think the ongoing just immense need for mental health counseling and access to child and adolescent psychiatry is still kind of a huge theme. And I know we're kind of just constantly like, did they get a new psychiatrist? Did they get it? So there's like this still run around of who's got what, where, when, and how. And I didn't know if there was a more centralized communication place we should be looking to know about staffing. Or I know Robin Shep and Robin Miguel, they've been great at giving us updates about our local county health departments and what services they carry. But I didn't know if you guys were having similar issues or had any advice in that regard.
I think that what I can share and then ask for Ollie, Robin, anybody else who wants to jump in. Throughout the pandemic, there have been several different times where various different groups have updated the resources that are available, but some of them are more specific to a certain county or region. I know that there is a lot of work being done now collectively through some community-based organizations like Common Ground Health and like through the Office of Mental Health and other places where they're talking about trying to develop some type of a coalesced directory. I saw what the message was in the chat. I think it was from Carol in terms of people who are available, what insurances they accept, what they specialize in. There is not like one specific source at this point that I can say, but what we can do, and because I think it was happening on a more regular basis, and I have to say, I think like the rest of the world, it feels like almost everyone has kind of thrown up their hands a little bit and just like been overwhelmed the last few months. It would certainly be a nice time that we can go back to some of the people who were sharing lists and ask for their updates again and share them out. I know Linda Alpergillis was doing that for pediatric behavioral health and wellness. They had some staff members that were doing that, and also for some of the regional services. We can certainly look to coalesce that and share that out with you all. Without question, the need is high and the number of resources are not as high. But I do think that trying to work together as collaboratively as possible between primary care and behavioral health at the schools. That's our best effort that we can make for these kids. Robin, do you have anything else you would add?
Yeah, I just wanted to say that the landscape changes so rapidly in terms of not only turnover with providers, but what they're able to manage and do. And so I know that, the Monroe County, at least mobile crisis team, has also increased some of their staffing and some of the availability of consultation and coverage and really some crisis intervention services that are very different. They've really needed to expand their staff and their outreach for some of those more acute situations to sort of divert from the ED. So there certainly has been expansion in that area. But in terms of outpatient mental health, it's the typical. There are a lot of staff turnover, long wait lists. I think what we've done, is on the social work team for PEDS is really just try to utilize one another, because chances are with the geographic region that we cover, we're trying to get a sense of what's moving and shaking where, whether it's with a private outpatient clinic or something new that pops up on a certain side of town, and getting a sense of just access. Sometimes it's who who's got an opening, and it's terrible that it has to be so random sometimes, but honestly, it's a changing landscape, and more than ever, we ourselves have been needing to do some of that brief intervention and even longer term work with the kids and families at our practices. And furthermore, there is even more work being done out of absolute necessity with the schools. So those schools who have embedded outpatient mental health therapists, who have school counselors, who have school social workers, we have really needed to lean in and build stronger collaborations and comprehensive meetings to talk about kids and leverage supports across community, school, PEDS, home. It's just a very changing time in terms of funding and availability, and just a deficit of providers. So, and the acuity of the patient and family need. The resources are very finite. So it's moderating risk and trying to be creative and advocating where we can.
Thanks, Robin. Katie, thanks for bringing that up. And Carol too in the chat. Okay, I think I had a couple of private messages with questions, and I think, Pat, did you want to just touch base? Did you have a couple of things just to share? Thanks.
Sure. Again, thanks for having me on the call tonight. It's always helpful to me to kind of get a sense of what opportunities we can use to leverage some of the academics that we have at the Children's Hospital. And, hearing about the neonatal components, I think that we have an excellent venue. As a matter of fact, we had our meeting from 4 to 5 today, but we have essentially an upstate regional touch base with a lot of different practices in the rural communities. And that might be a really good venue to actually have a neonatal series that we could put on to answer some of the questions that you brought up here. And as we move into the next 5 years or so, our focus is going to be to try and establish stronger networks with our partner hospitals, but also with anybody that's interested to try and access some of the educational capabilities that we have. We've been able to recruit fairly well over the past couple of years, and we have some just fabulous young people that have really kind of energized things. So if that's of interest, if you could reach out to Renee, I would be happy to facilitate that. And we have some other educational opportunities that are coming up, and I will, if it's okay with my colleagues at AHP, I will actually go through them, and we can reach out to you to keep you up to speed. And we're going to try and videotape as much of these things as we can, so you can have access to them. I understand there's a lot of financial pressures for everybody. So I think the real key here is to really focus on our unified system of care, and working with some of the folks over at RRH as well will be important to make sure that we have a good broad audience for these initiatives. But I'm quite sure they would be supportive of this as well. So.
That's great, Pat. Thank you.
Of course, thank you.
All right. I'm opening the floor one more time. And now I'm making an observation. Do you realize we didn't actually talk about COVID tonight? Though it was very present in the room with me. Well, hopefully not so much anymore, but it has been present in this. It has been present in this room. This is my little isolation bedroom in my house where I've been living for the last 5 days. I just want to wish you all a really good night and a good rest of your week. And I've had a lot of time to lay in a bed, coughing and reflecting, and I just really am grateful to work with all of you. And I think about what we have done together and what we will continue to do together is really special. So I thank you for your time, giving me back 20 minutes of your night, and we'll be back together again in early June. And we'll see you on the next Wednesday call, which is that, I've lost track of what weeks is it. Next week?
Next week.
Next week, Wednesday, we'll see you on the Wednesday call. All right. Take care, everybody. Have a good night and thank you.
Get better, LJ. Thanks everybody.
Bye.